Welcome to the Perimenopause and Midlife podcast. I'm your host, Terry Betsakis, and this is where we talk honestly about midlife, hormones, mindset, and becoming who you want to be next. Welcome to the Perimenopause and Midlife podcast. I'm your host, Terry Betsakis, and this week I'm talking with Dr Marita Long. Marita is a Victorian-based GP working across clinical practice, medical education and research. Marita has a strong interest in women's health and cognitive health, but enjoys the breadth of general practice. She is a current committee member of the Australian Society of Psychosocial Obstetrics and Gynecology and a member of the Women in General Practice RACGP committee and is the president-elect of the Australasian Menopause Society. She is the first GP to be appointed as an honorary medical advisor for Dementia Australia. Marita works as a lecturer at the University of Melbourne Department of General Practice and Primary Care and is a clinical associate professor for the Wicking Dementia Education and Research Centre. She was the co-host of Dementia in Practice podcast for the first 3 seasons and is the current host of Health Ed's 45 Up podcast. Welcome, Marita. It's such a pleasure and an honour to have you.
Oh, thank you so much, and thank you for the very kind introduction. It's lovely to be here.
I'm so chuffed to have you, and I'm sure that the ladies listening are going to get so much out of what you have to say, because I know I have learnt so much from you, and I'm looking forward to sharing some of that knowledge with everybody else. Can you share a little about yourself, what you do, and how you support women in perimenopause?
Yeah, so as you said, I'm a GP, and probably by virtue of being an older female, menopause found me, to be honest. So I was a member of the Australasian Menopause Society, and by virtue of that, you're on a Find a Doctor website. So women started coming to me, and all of a sudden I thought, oh, holy dooly, I'm going to have to learn a bit here, because, of course, we weren't taught a lot about menopause in medical school or in general practice training. We did some, of course, but it's such a nuanced space. So I guess that's how I came to be working in this space. And I suppose what I try and do, and remember, nobody is perfect. No one doctor can meet every single patient's needs. But I guess what I try to do with women is take time, for starters. So you can't do menopause medicine quickly, so allow time. And it's trying to get the story out, because menopause comes at a particular time, or perimenopause, a particular time of life for women where there's a lot going on. You can't just treat perimenopause or menopause. You need to treat the woman who's sitting in front of you with all of their complexities and the richness that comes with that. So I think my key thing would be trying to listen and trying to help them navigate using the best evidence that we have.
Yeah, that's very powerful. And as somebody who does consult with you, I can say that you definitely take that time, and I feel heard whenever I'm coming into the clinic. I definitely feel heard. So I can definitely attest to that. There has been a lot of controversy around hormone therapy over the last 20 years. What are your thoughts on hormone therapy, and do you recommend it for your patients?
Yeah, it's a really good question, and a battle that I think we're all still fighting, and that's the result of the Women's Health Initiative that came out in 2002, which sort of saw the end of the use of hormone therapy. It really frightened women that it was all bad. And since that time, they've actually unpicked the study and found out there's a lot of actual good information and positive information. Do I recommend hormones? I recommend treatment for women who have symptoms. And I think that's the really important thing. When women go through perimenopause or complete the journey with menopause, most women's bodies are going to adapt to a low estrogen status. But it's the women who are having troublesome symptoms who really get the best benefit from hormone therapy. I guess the other group that we pay particular attention to in terms of recommending hormones is for women whose bones aren't doing so well. So it's certainly not a blanket rule. I don't believe every woman needs hormones. I think many need some. And I think there's other women, there are a percentage of women who actually don't want hormones or actually sail through menopause. We don't particularly love those women because they seem to have a much easier ride, but there are women who don't need them and who don't want them. So I recommend them for the right population, I suppose, is what I'm saying.
Yeah, that's fair. Absolutely. There's no such thing as a one size fits all, is there?
Absolutely.
There's so many different symptoms. Yeah.
Yeah.
And one of the symptoms that I know a lot of women speak to me about is vaginal dryness and reduced libido. Is this something that you can help with? And if so, how?
Again, really important question, and an interesting one about the vaginal dryness, because I think most women are going to experience that. And that's a symptom that generally does not get better. It doesn't resolve itself. So for women who are experiencing vaginal dryness, painful sex, frequency of urination, we refer to those as the genitourinary symptoms of menopause. And they are very treatable. And most women, it's going to be very safe to use vaginal estrogen. That works incredibly well. There are some women who it may not be the best choice, but there's often some really good choices around vaginal moisturizers that we can use. There's a newer kit on the block, which is called Intrarosa, that some of your listeners might be familiar with.
I'm interested in that one, and talk me too, yeah.
That's a DHEA derivative, and I can never remember the whole word, but essentially it's the precursor to testosterone and estrogen that activates once it's in the tissues. So this is quite a good option for women who either have had a reaction to the estradiol or the estrogen creams or pessaries, or for women who they're just not quite cutting the mustard. We refer to the Intrarosa as the Viennetta, or the Sara Lee of the vagina, because the thought is that the active ingredients penetrate beyond just the lining of the vagina. They go into the deeper layers. So you think of the layer upon layer upon layer effect. And for some women, that seems to improve the discomfort of sex. It seems to give a better result. It's not on the PBS, so it's expensive. So
Of course it is.
We'd usually opt for the other treatments first. And for most women, I'd have to say they do work quite well. But the take-home message here is that they're common. These symptoms are common and they are very, very treatable. The thing I found in practice is often I'll ask women when I'm probably doing something like a cervical screening test, do you have painful sex or any discomfort with sex? And a lot of women kept saying no, no, no. And I thought, what's happening? I thought, these symptoms caused pain. And then I started asking, are you actually still having sex? And then they're
That's
like,
a
oh,
great
no.
question. Yes, you wouldn't think of that, would you? Because, how would they know if it's painful if they're not having...
If they're having sex.
Yes.
And it's something people are embarrassed about. So when you actually ask the question, then people are very happy to answer it, and they'll say, no, I stopped having sex years ago. Why was that? And it's not usually because of low libido. It's usually because it was painful or uncomfortable, and it is so easily treated.
Oh, what a great point to bring up.
Yeah. So for anyone listening, if you're having those symptoms and your doctor hasn't raised it, just next time you're there, just mention, while I'm here, I just have had this problem, and very, very treatable. Now, the low libido, that is a very complex question.
Sorry.
So I would say in my practice, if I was going to be very, very honest, probably women from their mid to late 30s seem to lose interest in sex. Now, is that because they've completed having a family? Is that because they're so bone tired from working and looking after their kids and carrying that mental load? Is it because their partners don't pick up their socks or fold the washing ever or contribute to that domestic load? It is a very complex mechanism. Men and women's sexual appetite seems to be very different. So I've spent a lot of time talking to women about what we call a libido mismatch. So this is where one partner has a high libido, the other person not so great interest. Women feel very embarrassed and feel like they're not quite themselves, and it can be quite distressing to have lost that. Men can feel, and I'm talking about, heterosexual relationships here, but men can feel quite rejected and hurt and feel like, their partner's not interested and doesn't love them anymore because they don't want to have sex with them anymore. But it's this whole sort of complex array where we have to start unpicking, I guess the psychosocial aspects behind intimacy and how we work with that. So that's a big picture. What we probably see in perimenopause or menopause is that not only has desire dropped off, but your ability to respond to arousal also becomes more challenging. So this is where not only do you not really feel like it, but when you're tapped on the shoulder and you think, oh, well, let's get into it, you don't respond as well anymore. And that can be distressing for everyone because it's becomes very unsatisfying.
Yeah.
So for women who are in this situation where they have a low desire, they have difficulty responding to arousal, and it's causing them distress, they no longer feel like themselves. They feel like part of themselves has died. That's what we would classify as hyposexual desire disorder. And that's where the use of testosterone can be incredibly useful. So it's been approved for women with that indication and very easy to use. It's very safe as long as we're monitoring it properly and can have great benefit. Not always. It doesn't always change everything. It doesn't mean that all of a sudden you're going to be looking around and trying to grab your partner into the bedroom. It just might mean that, you're feeling a little bit more like it and you can respond a little bit better. But it's not going to take the place of some of the discussion and some of the work around, well, what do I need as a person to feel like I want to engage in sex? I certainly don't want to be picking up everything and doing all the housework and putting everyone to bed and making all the phone calls for whoever's birthday it is and then getting to bed and feeling like, yeah, look, I'm into it. It might be that you need a bit of whining and dining. It might be that you want to, just have some closeness without necessarily having penetrative sex. So it's a big conversation.
It certainly is complex, and you've tackled it from every angle. So thank you for answering that question. I kind of threw you under the bus there, so I apologize. But I think you're right. It's definitely something where communication comes into it, communication with your partner, communication with your doctor, communication perhaps even with your kids about picking up some of the socks so that you're not doing so much, and then really establishing, okay, where is my lack of libido really coming from? And yeah, it's definitely a conversation that I have with a lot of ladies that I work with as well. And you're right, they do feel less like themselves, in many aspects. And it can be quite confronting because you're like, especially if you've been quite an active person in your younger years, and then you're like, what's wrong with me? And we kind of, I know for myself, when I was going through the crux of it a few years ago, I felt like this freak. And I'm like, and I'm somebody who's studied hormones for years. And so for me to feel that way, I can imagine general population who's not really educated in this area. There's so many questions and, you would hear all sorts of stories, I'm sure. So thank you very much for sharing that. I think it's powerful for ladies. Do you think there are, or not do you think, what are some of the other symptoms of perimenopause that are not so common? Like we know about, hot flashes and sweats, which is, everyone talks about those. But there's so many other symptoms I understand that, perhaps we don't realize are hormone related. If this podcast is resonating, I'm Coach Terry Batsakis, a nutrition, mindset and health coach for women navigating perimenopause and midlife. I support women in managing hormonal symptoms, feel more at home in their bodies and move through this phase with confidence and clarity. If you need support navigating midlife, you can find out more about working with me at terrybatsakis.com.au.
Yeah, there's a whole multitude of symptoms. If you jump onto the Australasian Menopause Society and look at the AMS symptom scorer, you'll see this whole host of symptoms. Now, recently in the UK, they did a big survey called the Menopause Mandate Survey, which was of 15,000 women. And they actually put brain fog as the most common symptom. So that's one that, I see women coming to me feeling like they're almost going mad, that they can't find the right word anymore, that they're forgetting appointments, that they're telling their kids to pick up their hockey stick when they actually mean their tennis racket, that the right words just aren't coming out, that it can be impacting on their ability to feel confident in the workplace. It can be incredibly challenging. And so women start thinking, oh gosh, is this the early signs of dementia? And I think that that's a symptom that is worth talking about, because I think a lot of women are suffering there thinking something terrible is going on. Now, we all know that as we age, our brains do start to slow down, our processing speeds and our memories, really from third or fourth decade of life. So everyone, even men, are experiencing these changes. I think what happens in menopause is we get this fluctuation of hormones, and we know that our brain is full of hormones. We know that menopause is indeed a neurological transition as well as a sort of sexual and reproductive transition. And so that adds, to the changes in the brain. If we test women's cognition, if we give them a cognitive test, there will be some delays maybe in verbal recall and memory, but overall their cognition is fine. And I think that's a really important message. All of us have, as we get older, we have crystallized knowledge in our brain. We have good life experience. So that can compensate and allow us to feel like we can keep up with the cool kids. That's the first thing. Our brains are normal. You are not going mad. You do not have dementia. This is a phenomena that we've always known has been there, but I think since COVID and more cancer treatments and chronic fatigue, we have this understanding of brain fog, and it's really hit the perimenopause and menopause space. So brain fog is one that is very common and can really be distressing for women and worth a conversation. Hormones don't help brain fog. There's no change in cognition. If we give you hormones, we can't see an improvement in your cognition. However, if it helps your hot flushes, so you're sleeping better, and if it helps you exercise because you're feeling better, and if it helps you pay attention to your diet, this is, treating someone with hormones because they're feeling pretty rubbish. Of course, our cognition is going to feel a little bit better. So that's the brain. And the mood and anxiety, that can sometimes be some of the first symptoms of perimenopause, particularly for women who have had PMS or PMDD, very profound cyclical mood changes. They might find that's happening in menopause. And it's not the depression of menopause isn't necessarily a sad or melancholic. It's more an irritable, angry. I don't like anyone anymore. Everyone irritates me. My husband chews too much or too loud. That irritates me. And it's uncomfortable for women. They don't like to feel like that. So there can be these mood changes that aren't classic depression. And then the anxiety. We can often even see palpitations in menopause. You can start feeling this speeding up of your heart. So they can be symptoms that can be associated and might take a while to pick out, oh, hang on. Yeah, actually, I am bleeding a bit more. I am bleeding a bit less, or my cycles have changed a little bit. It's only when you stop and think, because again, often we're very busy, not paying attention to those changes. Aches and pains, lots of women talk about just feeling like an old lady, and you'd probably see a lot of that. Women who are just feeling like they're an old lady, they can't move as well anymore. It's harder to get out in the garden. It's harder to do those long walks. It's harder to go to the gym. So this sort of aches and pains, old lady-like feeling kind of come in. And
tightness in moving and
yeah.
Sure.
And so then people stop moving. And of course, that's, again, one of the worst things that you can do. And then you can get the dry skin, hair changes. So hair where you don't want it and losing hair where you do want it. So there's all the things,
Peel
all
it
the
off and
joys.
stick it on.
So there's lots and lots of things that can be happening at that time of life. But we have to remember also, Terry, and I think this is really important, there can be other causes for those symptoms. They're not unique to perimenopause or menopause. So we can't just blame everything on perimenopause and menopause and not dig a little bit deeper to check if there could be something else going on. And I think that's a really important take-home message. We don't want to blame everything on perimenopause and menopause.
You could miss something very vital. Yeah, absolutely.
Yeah.
It's looking at the big picture, isn't it? Instead of just looking at something as an isolated symptom, it's like looking at every factor and then also looking at medical history. That's something I've learnt from you.
Yeah, really important. You've got to think about what else could be causing these symptoms. And when you're sure that there's nothing else, it's kind of like then you go, I think this is going to be related to perimenopause and menopause, and this is what we're going to do to get you feeling better, get you feeling more like your normal self.
Well, that's a really great segue into my next question, which is what are some of the tests that you can conduct for ladies, perhaps to determine whether they are in perimenopause, or once you have determined that they're in perimenopause, like what are the follow-up tests that you then do?
And again, I think this is a really important message that there probably are no essential tests that we need to do, particularly if we're thinking about wanting to get started with some treatment. If someone comes to me and they're clearly perimenopausal or menopausal and there's symptoms there, usually we are pretty safe to start treatment from the get-go, but there might be things that we need to have in the pipeline. So, for example, we want to make sure people's cervical screening is up to date. We want to make sure that mammograms are up to date. We want to make sure if someone's got heavy menstrual bleeding that they're not iron deficient, they don't have fibroids, polyps. So it might be that we need to do a transvaginal ultrasound. We might want to check someone's overall metabolic health because that can be really important. We know that the metabolic health changes in the midlife. So we want to make sure that cardiovascular markers are okay, that there's no emerging diabetes or impaired fasting glycemia, the pre-diabetes, for example. So we might want to check thyroid function. We very, very rarely need to check the reproductive hormones. We very rarely need to know those because, one, in perimenopause, they're going like this. So it sort of depends on the day we take them. So that can be misleading. And post-menopause, well, once you're post-menopause, we know your estrogen's going to be in your boots and we know your FSH is going to be high. So it's not going to change what we do. There are exceptions, of course. There's no, as you said in the beginning, there's no one size fits all. So there might be some times where we do need to do those tests, but generally there's no essential test before we start treatment, but there might be things that we need to be crossing T's, dotting I's for.
Yeah, perfect. Thank you. Thank you very much. That was nice and concise right across the board, because I think that can be a little bit daunting for people as well. Or, they think, oh, I'm just going to go and get a hormone test and see what my hormones are doing. And one
Yeah.
of the things that I commonly say when I have this sort of question is, well, at this point in your life, your hormones are fluctuating so much. You
Mm.
might be within range now and in 5 minutes you're not. So it's very difficult to kind of tell just from a hormone test. So it does need to look at big picture.
Yeah, for sure.
Now, you do a lot of work with dementia. Is there
Mhm.
anything that we can do to reduce our risks as ladies or slow our symptoms? And this is probably one for the guys as well, not just for the ladies, but we're talking to ladies, so let's talk at ladies.
Actually, it's a very important thing for women because we know that 2 out of every 3 people living with dementia are women. We don't
I
know
didn't
why
know
that is.
that.
Mm. So we don't exactly know why. Partly it's because women live longer, but that's not enough to explain the full picture.
Right.
So it's a really important thing for women to understand that midlife is the time to start looking after their brains. So dementia is a clinical syndrome. It's not a disease in and of itself. It's caused by many different diseases. Alzheimer's is the most common cause of dementia in Australia, followed by that is vascular dementia. But often we'll see the two coexisting. So it's
Wow.
really important that women are paying attention to those midlife vascular risk factors. So what does that mean? And it sounds very simple, but Terry, you're working with women all the time. You know, it's not that simple to achieve. I get women to stay roughly in the healthy weight range. Yep.
Yeah.
We want to make sure women are exercising, getting blood to their brain, really important.
Mm.
We want to make sure women are getting good sleep. Again, really important. That's a time where we clear a lot of amyloid from our brain. It's where we sort of
Such a challenge too in midlife, the sleep
such a
side.
such a challenge. So getting good sleep, good rest, making sure you're keeping up with all your checks like your blood pressure, cholesterol, your diabetes checks, because they are big risk factors for dementia. And the pathology for dementia, so the changes in the brain that are going to cause one of these dementias, start in our midlife, but the symptoms don't become evident for decades. So
Wow.
midlife is the time, if anything is going to motivate people into some changes, it should be that this is a time where our brains are becoming vulnerable to the different risk factors that can increase your risk of dementia. Now, other things that are really important in midlife is hearing. So hearing is a significant risk factor, and correcting your hearing in midlife, because of course that's going to keep you staying socially engaged. Again, a really important. Loneliness and social isolation are a big risk factor for dementia as well. So we want to be interacting, using our brains to talk, to have conversations, to go out to movies, to go to museums, to, start a new class, whether it's an exercise class, a painting class, a dancing class. Learning new things is incredibly important for our brains throughout the life course. But again, midlife is a time where, as women, we really need to say to ourselves, what do I need to keep myself healthy? Women live longer than men, but generally in poorer health. So what do I need to do today to help me live that'll make me feel better now as well, but will help me live a better life? So it's not to scare women, because, not every woman ends up with dementia.
Yeah.
It's still a small number overall, but our brains are incredibly important. And so we want to do whatever we can. And eating well is probably the other thing I would say is
Yeah,
incredibly
what we
important.
put into our body is what it produces. Yeah,
Yeah.
correct.
So
No, that was fascinating with regards to the hearing and the isolation and loneliness, socialization. It's
mm,
something that I know I've never thought about, but as soon as you
mm,
mentioned it, I was like, oh, that light bulb moment that appears in the cartoons. That just happened to me. I just went, wow, that's so true. So
And for
I guess
women, particularly in Australia, I'd say physical inactivity and obesity, and actually depression is emerging as probably some of the biggest risk factors. Yeah.
Well, I suppose that would be associated to a decreased level of oxytocin as well, because that's our social love hormone. So if we're not socializing and we have a reduced oxytocin, then that impacts serotonin, dopamine, all our happy hormones. So you can definitely see that relationship there, that's for sure.
Yeah.
Wow.
So keeping socially engaged and physically active. And I think that's why things like probably park run, have sort of taken off around the world as a way that is easy for people. But of course, we need to be thinking also for women in midlife, we've also got to be thinking about balance and strength. They're also really important things when we're thinking physical activity as well.
Yeah. And it's interesting because I know from a balance and strength perspective that I speak with women, I'm like, don't you want to be able to get on and off the toilet until you're 90? And they just look at me like, what? And I go, well, that's a squat, right? So if you're struggling with squats, you're not going to pop one to be able to pop one, right? And they just go, I didn't think of that. And I'm like, it's just that functional stuff, like being able to pick something up off the floor, being able to hold a grandchild, or, if
you're get yourself up off the floor if you fall.
If you're correct, if you fall. So, so super important, especially with osteoporosis too, because you touched on that with regards to the hormone therapy earlier, that if you're a risk factor for that. So, all super important to be able to just give functional life, I guess. These are all things that I've learnt from you. Any other final tips before we wrap it up? Because there's been some we didn't get gold nuggets from you today. We got like full gold bullions. It's been sensational. Any final tips?
I think the thing is that I'd say is that midlife is the time where you do need to find a doctor you feel comfortable, and it's not going to be a one size fits all, but finding someone who will help you navigate through your midlife and beyond, because midlife is a time, as I've said, that's going to set you up for not only a good time now, but a healthy, future. And I think that's, as women, I think we've got to take that step to, in a sense, take charge, which can be incredibly hard when life is so busy. But if an investment in a GP who you feel comfortable with, who you can be honest with, who you feel, does hear you, does listen to you, and works in a way that's helpful for you. And it's, as I said, not everyone works well with me. It's a very, very sort of individual fit for lots of people. So just finding that person, asking the reception at any general practice, asking your local community group, getting some ideas of who's around, who can help you navigate midlife and beyond is super important.
Great advice. Great advice. And it's true, like we've all got different personalities, right? So we're going to gel with some people and not with others.
Yeah.
And I think it's super important to just be with someone that that A, you feel comfortable asking questions of, B, you get heard, and C, are willing to explain things to you if you're not, really a science kind of person who's going to understand this stuff. Putting it in, having a bedside manner, I guess, is the thing.
Being able to share the decision making, being able to understand what's being presented to you in a way that you feel comfortable that, okay, that makes sense, I'd like to try that, or no, that doesn't sound like that is something I'd like to try. Could we try something different for starters? That kind of stuff.
Yeah, perfect. Marita, it has been an absolute pleasure. Thank you so much for all of your gold bullions.
Thanks.
It's been really, really eye-opening on so many levels.
Well, hopefully it helps.
I'm sure it will. Like I said, I'm pretty educated in this area, and you've taught me a lot, that I didn't learn in my own courses and things that I've studied. So I've learned a lot. So I can imagine, all the ladies that are out there listening, how much they've learned as well. So
Right.
Yeah, I appreciate it. Thank you. Thank you for your time, because I know how incredibly busy you are. So thank you for
it's a pleasure, absolute pleasure.
Okay, well, that's it for this episode. Thanks again for listening to the Perimenopause and Midlife podcast. Please join me again next week for another episode. And don't forget to subscribe and share it with another woman who may enjoy it as well. Remember what it's like. Don't keep things you love to yourself. Share the love. Stay awesome, everyone. Marita, thank you again. I will talk to you very soon.
Thanks. See ya.
Thank you for listening to the Perimenopause and Midlife podcast. Join me next time for more honest conversations about midlife and what's possible from here.